Good morning, everybody. My name is Marian van der Schueren. I'm a dietitian by background, and I have been a co-author of the ESPEN Oncology Guidelines. The Oncology Guidelines were published in 2017 under supervision by Jan Arends, and there's both a scientific paper as an expert group recommendation for action. The guidelines, as just summarized, contain many practical recommendations on nutritional screening, nutritional assessment, body composition measurements, diagnosis of malnutrition, and they also give guidance to an individualized dietary advice. For example, by proposing more than 1 gram of protein per kilo and 25 to 30 kilocalories per kilo. However, these guidelines do not contain recommendations to translate this amount of protein or these kilocalories into food. And they also do not tell us how we can motivate the patient to meet requirements. So these practical translations are lacking. This is important because a patient does not eat kilocalories or protein. He eats food like bread, protein-rich food, vegetables, and fruits. I want to illustrate the importance of eating and eating enough on the ESMO guidelines that were the ESMO systematic review that was published in 2018. We reviewed dietary intake studies and did a meta-analysis of the evidence of nutritional intervention to support patients with cancer. We did not publish the data that I'm showing you now on the screen, but it's important to understand what's happening. You look at randomized clinical trials. Patients were given a dietary advice or oral nutritional supplements and advised to increase their intakes. And the recommended intake is in the blue thick line. What you see in the 3 studies depicted here is that even in the intervention group patients, most of the patients never reached their dietary energy goals. And if we're looking at protein intake, you see the same thing. Most of the patients never reached their dietary protein goals, not even in the patients that were in the intervention group in these studies. So what we saw in the meta-analysis, that dietary counseling or nutritional supplements did improve weight, but not statistically significant, can partly be explained by the fact that the patients never met their dietary requirements. A newer study, the EFFORT trial from 2019, nicely illustrates that meeting dietary requirements can be very effective. You see the red lines and the blue lines. The red lines are the patients who received their dietary requirements, hospitalized patients, versus the blue lines, the control patients, and the ones who received their optimal diet, they had less adverse outcomes and they had a better survival. This underlines the importance of a good dietary advice that enables patients to reach their dietary intakes. So this is where the dietitian comes in place. If a patient has cancer and he is expected to live for at least 3 months, he is first screened for nutrition risk and a diagnosis on nutritional status is made. If the patient is found to be at risk, a dietitian comes in and performs a comprehensive dietary assessment. This consists of nutritional status, metabolic status, functional status, symptoms impacting on nutrition intake, GI function, pain, dyspnea, psychological distress, medication, and tumor status. Based on this comprehensive nutritional assessment, the dietitians start a tailored intervention which comprises all of these points of attention. If a patient is not at risk, he should be rescreened at regular intervals. And if a patient has a relatively short life expectancy but is experiencing eating-related distress, the dietitian can help to relieve this distress by giving nutritional advice on, for example, cachexia, treat symptoms, and offer psychological support. The dietitian takes into account symptoms like pain, nausea, vomiting, the mood of a patient, his therapy and the expected side effects of the therapy, recent changes in weight, and the tumor stage. She translates all this information into food, for example, into foods rich in protein. Also, she can advise on taking extra supplementation, vitamins, minerals, or even enteral or parenteral nutrition, oral nutritional supplements, and she will take into account the treatment and the side effects coming along with the treatments, such as mucositis, vomiting, diarrhea, or pain. And I'm very happy that ESPEN and EFAT have decided to join forces, because dietitians are the experts to translate science into practice, science into a practical advice for patients. And also, I think every guideline should involve at least a dietitian to perform these tasks. So I hope that in future ESPEN guidelines, always an EFAT member will be involved. Also, by joining forces, I think the guidelines will have a larger impact, because dietitians are involved in delivering and optimizing nutritional care of cancer patients in the wards, at home, and they also play a role in education of medical doctors and nurses. So I think that the collaboration of the two scientific, both ESPEN and EFAT, will help to improve the effectiveness of dietary interventions in patients suffering from cancer, and to improve the patient-centered outcomes. I think that I hope that implementation of guidelines will go to a higher level, and this will result in optimal nutritional care for all. I thank you very much for your attention, and I wish you a good virtual ESPEN. Thank you very much.